Hi, good afternoon. The patient is a 50-year-old woman who has come with headache, fever, and also while eating noticed severe jaw pain. So this is what the patient has come with, and what we were thinking. Does anyone want to guess what the diagnosis is? Yeah. So it's a giant cell arthritis is what we were considering. So the next step is a temporal artery biopsy. Now the problem is she wasn't really willing for the biopsy. So now the questions arise: can she have another test, which is ultrasound, which is an ultrasound? Can this replace a biopsy? And so that's what we are trying to do. So they've gone through multiple articles to come to the hypothesis, and the article I'll be reviewing is this. It's called the THAMBU study, which will help come to the answer of the question which we've had based on the clinical scenario. So the aim of the study is looking at the clinical effectiveness of using ultrasound to finally diagnose a patient with giant cell arthritis versus the biopsy, which is currently the standard which is being used. So this is just before we start. So how it works is they do an ultrasound, the Doppler, and they look at this. This is I think the artery, and they look at this area around the artery, and that is called the halo site. So just a brief into that. Secondly. So next is histopathology of what the biopsy will show. So biopsy shows infiltrates. Usually it's a transmural, but can also be localized. And then they look for giant cells. So this is a picture of the giant cell here. This is a giant cell. Not sure very clear, but so they look at to diagnose a person with a giant cell arthritis after they do the biopsy. So finally, now we come to the critical appraisal. So the first thing is this study valid? So I'll go through each of these questions one by one. So one thing is, was there a clear question for the study to address? So here we look at the patients, the population of patients with giant cell arthritis suspected to have. The intervention what we're looking at using ultrasonography to identify this, and also biopsy. Now the gold standard, which is the reference standard used for this, is what I'll come to, because there is no ideal one test reference standard. And then the outcome is comparing the intervention to the reference standard, and it was done between 2010 to 2013. So now it was a prospectively done cohort in multi-center cohort. But if you look at it, even though there were 20 centers which were said in the study, and it seems extremely large, the majority of it was actually from 2 centers. Just wanted to highlight that. One was Norway, one was in UK. So now the patient population. So this is the inclusion-exclusion criteria. The inclusion is patients who are referred with giant cell arthritis. One thing I want to highlight is, even though the most criteria like the ACR, EULAS says that patients above 50 is one of the main criteria, this study took patients more than 18. So that might overestimate or put other false vasculitis in this study. That was one drawback to inclusion. Otherwise, inclusion and the exclusion criteria were well written. And they ruled out patients who are on steroids for some other disease, because that might have actually even modified the patient. They might miss it up with the test. So these are reasonably done inclusion and exclusion criteria. Next is the interventions. So now the question is ultrasonography of the temporal and the axillary arteries. It's a subjective test. Whoever does it, I might pick it up, I might miss it, but a senior radiologist might pick it up. So now, how do they overcome this? And this is what they did. They had a training which was video-based training, and then they had a competency assessment done. The probe use was meant to be standardized, and they were all asked to fill a pro forma of everything. So with this as best that they could, that is the CRF form, they tried to make it standardized. But in spite of all this, there would definitely be a minimal amount of observer operator expertise, which would also favor some people to pick it up, but they tried making it as standard as possible. The next thing is temporary artery biopsy. So here it requires 2 teams. One is a surgeon to do the biopsy, and the second is a pathologist. In this study, there was no hindrance to the surgeon. The surgeon just had to do the biopsy. There was no level of expertise that was asked to the surgeon to document. So that was one drawback, because you would prefer someone who's done multiple biopsies, because even the biopsies have requirements like a 1 centimeter artery taken. So they should have included the surgeon, some expertise level prior to do this. The second thing is the pathologist. So here again, the pathologist did not have any prior training like the radiologist did. The reason is they thought the current standard of care is a temporal artery biopsy, so most pathologists will be well versed. So if the pathologists have self-declared that they are well versed with diagnosing it, that's all that was taken. They've had to fill a CRF form. And positive was compatible with the GC vasculitis, negative was another vasculitis, arteriosclerosis. So these were the two interventions that was done. Now the gold standard. So what do you expect from ideal reference standard is the tests which are being, the intervention is fully separate, the tests that are being evaluated are fully separate, and the gold standard is a completely different test. So PCR versus an antibody test. So that is an ideal reference standard. So for giant cell arthritis, there is no real gold standard test. So if this test is positive, it is giant cell arthritis. So that is a major drawback. So in this, what they've done is they looked at the clinician's final diagnosis. So a patient came to me today, and at the end of 6 months, they still feel it's the giant cell arthritis was one. Second is ACR-EULAR criteria. Third is emergence of complications. So giant cell arthritis is known to have complications: strokes, hypertension, blindness, associated polymyalgia rheumatica. Did they develop any of these during the 6 months? And the last is, did they evolve into another vasculitis? So based on this was the final reference standard which they used for this, which they compared all the other tests to. So what do I feel about this? One is it is subjective, and the reference standard actually includes a test which is part of the intervention. The biopsy, which we are studying the sensitivity and specificity for and seeing ultrasound better to that, biopsy is actually a criteria in the ACR, which is one major drawback. But in spite of all this, I think the gold standard was very well defined to the best of its abilities, and they have defined if the patient is positive by the clinician's diagnosis, fulfills these, then it is So then it is GCA present. Now next thing is if patient does not fulfill and neither fulfills these, then a GCA negative. But the question would be, when the clinician does not feel GCA, the patient actually does not really fulfill these negative, that's when they have an expert panel of 3 rheumatologists, and if 2 agree, then they go ahead with the clinician's diagnosis. But then if there's more than only one person agreeing the clinician's diagnosis, they have a panel of all 3 sitting together and come to a uniform consensus. So I thought, that was extremely well defined with what is available, so that's why everything's a well defined gold standard. The next thing, yes. So was there a comparison to the appropriate reference standard? This is what I previously said, where the comparison is actually using part of the intervention test as part of the gold standard, which might actually cause falsely elevation of the specificity of that test. Next is, did all the patients get the diagnostic test and reference standard? The answer is yes. So that means they are actually eliminating a verification bias. What that is if you have a patient like if you do D-dimer for a patient it's positive and negative, and the patients who are negative, you don't do the CTPA because you're saying it's negative, it's unlikely to be a pulmonary embolism. You might be actually missing patients with pulmonary embolism, D-dimer negative. So that way you're actually getting false negatives. So by not having both tests being done, you're actually getting false negatives. So that's the point of this, which is they do both and you're ruling out a verification bias. Now the next thing is, could the results of the test have been influenced by the results of the reference standard? The answer for this, according to this study, is no, because both tests were done independently at different time frames, and whoever did the ultrasound was not the person judging the clinical status and the overall diagnosing yes for the overall disease. And so they were done independently, and there was blinding of the physician here. The ultrasound, once the ultrasound was done, the physician was actually not told what the report was, so he was completely blinded also. Next is the disease status of the population clearly defined. It was again a elaborate CRF form which they filled for each patient, and so it was a very well defined disease status of the patient. So if you look at the baseline characteristics, which were all documented by the CRF forms, there were multiple tables. One is the demographic details, the patient symptoms, the lab diagnoses, the comorbidities, any prior treatment or risk factors. I quickly went through it. I've gone through it and highlighted the ones that are quite similar to our population. It's elderly. It's a group is around 60 to 70, female predominant. If you look at this, most patients actually have localized pain in the head, 80%. Job claudication around 40 to 50%, which is all what is actually seen. So the population which they've got is a representative of the general population that presents with this disease. Only one thing is Indian population here was around 1%, but it was a study done in Europe. Yeah. So the next thing is, what the methods for performing the test described in sufficient detail. They had a very well written study protocol and they followed the standard operating procedure was followed. Only thing is, there were 2 amendments which they documented that there were amendments, but I did not think that the amendments actually finally affected the outcomes. Amendment 1 is patients, when they presented with giant cell arthritis, were informed about the trial and they were told to take at least 24 hours before getting back saying they accept, they want to be enrolled. So they found that there was a delay in that. A lot of patients didn't come back immediately. So during the trial, they said patients can consent within 24 hours. The second thing is that they needed a sample size of 402. They realized there was some dropouts, so they increased the sample size to get the sample size of 402 to achieve the finite power and keep an alpha of 5%. So finally, are the results of the study valid? That is the aim of doing these questions. Apart from the second question where the appropriate reference standard was not there, but at present there is nothing else that could have been done. I felt it was a well done study. So I'll move on to the results. So what are the results and then how sure are we about the results? So what are the results? The primary outcome, we look at ultrasound versus biopsy, ultrasound versus the reference standard, and then biopsy versus the reference standard. These are the primary outcomes. So before going to it, I'll just go to statistics that we use and then I'll go into the final results. So one is kappa statistics. So this is to look at the agreement between observers or the test. So what we look at is there's an observer 1, observer 2 or test 1, test 2, and we see when are both these tests positive, that is A, and when are both these tests negative, that is D. So A and D means they're both concordant. So when you look at concordance, you do A plus D divided by the entire population. So the higher the percentage of agreement, the higher the concordance. And the statistic tool that is used for this is kappa. When they look at the percentage agreement, then the percentage agreement by chance divided by 100 minus the percentage agreement by chance. Generally more than 0.75 shows excellent agreement. 0.4 to 0.75 shows intermediate to good agreement, and less than 0.4 is poor agreement. The second thing is positive predictive value, which was discussed, and then the likelihood ratios. There's a positive likelihood ratio and a negative likelihood ratio, which is so it's always sensitivity on top and specificity in the bottom. Positive is when you have sensitivity by 1 minus specificity, and a negative likelihood ratio is 1 minus sensitivity by specificity. This will help when you have a pre-test probability, you have a Fagan's nomogram, and then you have a post-test probability, and that's the usefulness of the likelihood ratio. So we go to ultrasound versus biopsy. This looks into the kappa, the correlation between ultrasound and biopsy. So here the ultrasound positive cases in this study was 162. The biopsy positive were 101. The concordance when you calculate is, what you do is 74 plus 192 divided by the entire 381. So the concordance was 70%, the discordance was 30%. With statistics, they found that the kappa ratio is only 0.35, not showing very good association between ultrasound and biopsy. Now the main outcome which they want to look at was biopsy versus the reference standard. So here the biopsy sensitivity was only 39%. How do you get 39% is when you do, so you do 101 by 257, you get the sensitivity, and specificity is actually 100%. So here's again by doing 124 divided by 124 plus 0, and that way specificity is 100%. So then the positive predictive values and negative predictive values were calculated. PPV is done horizontally and NPV is done in the second row horizontally, and that is 100% and 44.2%. And the positive likelihood ratio is infinity for the biopsy. That is because when you do sensitivity by 1 minus specificity, and specificity is 1, you have sensitivity by 0, and that is infinity. So that means a patient who has biopsy proven giant cell arthritis has giant cell arthritis. And then the negative likelihood ratio is 0.61, not very great for negative likelihood ratio. We are targeting less than 0.1 and 0.2. We're hoping for. Ultrasound versus reference standard. So now we look at the previous test with biopsy, now the ultrasound. The ultrasound has a sensitivity of 54%, which is more than the biopsy of 39%. Specificity is not as great as the biopsy, 100%, 81%, but it's alright. Positive predictive value is 85%, negative predictive value is 46.1%. The positive likelihood ratio is 2.84, the negative likelihood ratio is 0.57. Neither were really significant, but yes. So now these were outcomes which they got while doing the study. So not what they were trying to show. But if you look at it, if you combine, if you do ultrasound and biopsy and look at the sensitivity and specificity, you can actually see the sensitivity improves if you do both together for a patient, 65% and specificity of 81%. Now, if you combine clinical judgment, which we might not have felt that is as important as doing investigations, but if you combine clinical judgment with just, so if you do biopsy with clinical judgment, the sensitivity of biopsy is 39%, but with the clinical judgment comes to 91%. Similarly, if you do ultrasound and clinical judgment comes to 89%, and if you have a patient's clinical judgment along with the biopsy and ultrasound positivity, it comes to 96%. So these numbers look staggering and look amazing. But again, if you remember, the only drawback is the study outcome is actually clinical judgment with ACR criteria with positivity. So if you have a clinical judgment previously positive, it just shows that it's very unlikely that your final outcome is going to be negative based on the outcome criteria which the study has chosen. So even though these numbers seem much better than doing the biopsy alone, they might not be fully real world data. So then this is just wanted to show you the sensitivity by 1 minus specificity graph, where if you look at the only biopsy taken alone, 39 sensitivity with the specificity is 100%, only ultrasound that shows sensitivity and specificity as per the graph. Now the inter-rater agreement is very important. That is because you're doing a biopsy and an ultrasound scan, but they're not done by the same person. This is done by different radiologists and different pathologists across hospitals. So now the question is there good inter-rater agreement or not? Again, this is what you look at CAPA, which we initially spoke about. And so here, if you look at the rate, and one more thing before coming to CAPA is the fact that if you look at it, actually, not all radiologists and pathologists participated in doing the inter-rater agreement. So the CAPA for the pathologist was 0.83 and the CAPA for the radiologist was 0.69. Both showing, so the pathologist had a much higher CAPA showing excellent agreement, whereas the radiologist had a moderate to good agreement. So that now for diagnostic study, it is very important to know the adverse events. Even if the biopsy was finally superior to the biopsy had so many more adverse events, then you would not really want it to be done, and you might still err on doing an ultrasound. That's just an example. So that's why we look at the adverse events. So the adverse events, the thing I want to highlight here, there is no serious adverse events. That is great. Mild adverse events, the scan had two, when they put the probe, there was some mild pain post that, and the biopsy had 63 definite biopsy related events and 10 possible. So mostly the wound problem, post biopsy problem, and pain, and one actually had infection, but there was no serious adverse event. So then these are not main primary outcomes, just want to highlight because it quite important outcomes from the study also. One is they looked at the clinical diagnosis with the gold standard. Just wanted to highlight that the sensitivity is high. This might be because clinical acumen is very important, but this might also be a mild drawback from the reference standard, including clinical suspicion as one of the diagnostic tools. The second is wanted to look at the pretest probability. So you have a high, medium, and low pretest probability. What is high pretest probability? When you have clinical plus lab parameters ESR, CRP high. What is medium when you have either or, either clinical or lab parameters, and low when you have neither. So just to show that as your pretest probability decreases, your sensitivity on picking up with both scan and biopsy also decreases. So finally, the next thing, the results which we gone through the sensitivity of both ultrasound and biopsy. So how sure are we about the results? So is it reliable? So I just wanted to show that when the graph is extremely wide and the confidence interval is extremely large, it might not always come in that, so it might not be very reliable. But in this study, the confidence interval is not very large, so that's why I said it is a reliable result. Look at the confidence interval for sensitivity is 33 to 46, and for ultrasound it's 40 to 60. I do not feel it was too large to say it's not a reliable result. So finally, it's a consequence and cost of the alternatives performed. So this was done. This was an European study. So they actually looked at the cost involved in just for them, and they found the biopsy cost is 9 times higher than the cost for the ultrasound, 514 euros with 58 euros. So they concluded based on the cost-effective analysis that ultrasound plus clinical judgment is superior to biopsy based on the cost-effective analysis. So finally, the thing is, will this, the most important part after the study was a well-done study, the results were also well described and we know the results. So can we use it for locally and for the patient which we talked about initially? So can the results be applied to your patient population? The answer is yes, because the patient population as seen by the baseline characteristics were very similar to what we see with patients coming with giant cell arthritis. Secondly is, can this test be applied to your population? The answer in CMC it can be, because the radiologists are tuned to pick up, have the skills to pick up a giant cell arthritis, but this might not be universally applicable. The thing is, they also provided a training document of how they did this, so people interested can do that. Next is, it is not cost intensive, which is great. Were all important outcomes discussed. So the main aim of this was to diagnose it, and the diagnostic outcomes of ultrasound was discussed. A positive report would aid the diagnosis of the disease, whereas a negative ultrasound report will not rule out the disease. And the last thing is, what would the impact of using this test on your patient's population? So if you look at ultrasound compared to biopsy, ultrasound is faster, non-invasive, there is much less adverse events rate. Economically it's more beneficial, and finally they actually looked at patients serially who were on steroids and found that the halo sign showed some reduction, so they feel it could probably also show improvement based on steroid therapy. There's some improvement, we could also highlight that. So overall there were multiple advantages on by using the ultrasound, but finally, if you look, would you advise the patient for doing an ultrasound instead of biopsy? I would say, based on this study, I would not, because ultrasound does not have too much higher sensitivity compared to the biopsy, and the biopsy specifically is 100%. So an ultrasound picking it up will not always mean patient has it, whereas an ultrasound not picking it up, you cannot rule it out. So unless the patient is not willing for biopsy, then it is an alternative option. But based on this study, I would not always recommend ultrasound over biopsy. Second is, so the second and third question, both should ultrasound replace the biopsy for this patient and be a reference standard. Both the study does not give enough evidence to say it should be the gold standard and it should replace biopsy, but it is looking at as a viable alternative option to biopsy as per the study.
What do you tell your patient? Start off with the patient.
Yes, so the patient, if the patient is, I would still counsel the patient for the biopsy, but if the patient is not willing for the biopsy, I would tell him ultrasound is an alternative option which can be used.
Okay, let's give Adarsh a hand. Any questions? There's much more to teach, but questions for Adarsh? So just remember, critical appraisal, 3 parts: validity. Any study is a study well done. If it's not well done, don't look at the results. If the study is well done, then look at the results. If the results are impressive, the last question is, should I change my practice? New treatment, new diagnosis, new prognostic markers. So that's the last question. So we always start with the story of a patient who suspected giant cell. I don't want biopsy, I want ultrasound. At the end of it, he's refusing biopsy. Will you treat him just based on ultrasound? I don't want biopsy.
So as per the study, it is nearly equal to biopsy, so I would treat him on the basis of ultrasound.
At the end of the day, I told you evidence-based medicine has 3 parts. The best evidence, your clinical experience, and the patient's preference. Patient affordability can't be an issue because biopsy is much costlier than doing ultrasound. So it's not a cost decision why he's saying I want, but he says I don't want to have a biopsy and be stuck with one big hematoma on my head. So I want only to do an ultrasound. Then you may land up doing the ultrasound. So that is the place where we end evidence-based medicine. Is it something that is easily available in CMC ultrasound?
Ultrasound is easily available and the report will come the same day.
How much expertise do you think required for our radiologists to learn temporal artery Doppler? So you have to have some idea of proper radiology. This is not very difficult to do other Dopplers. This is very easy in fact. So do you think the inter-rater reliability in our hospital will be good?
So because this is actually the inter-rater reliability, people who undergone the training and then doing this. In our hospital, people who are doing ultrasound are probably trainees, so there might not be as good inter agreement as per compared to the study. But as per the study, the agreement is good, so it should be okay.
So all over India, would you suggest for all small hospitals they should do biopsy or ultrasound?
Small hospitals, I would advise a training program followed by doing an ultrasound, because it seems in our setting that seems a more feasible option.
So economically, to have a biopsy, to have anesthesia, biopsy, surgeon and pathology. Whereas if you just have ultrasound, already the radiologists in every street corner in Vellore, ultrasound everywhere in India, ultrasound machines everywhere available. So the extra input that they have to spend to do this is zero. They just have to get some training in ultrasound. So that's the next question to think about. Alright, let's give one more hand. Okay, I've got some more to teach. If anybody has to leave, you can. And then I'm going to teach a little bit more about this. One aspect he talked about briefly but didn't cover. Okay, shall we just go to, can you make a blank?
Yes.
Or this may not go. Okay. So, what I want to tell about what little bit he talked about. Suppose a patient comes with jaw pain and fever. Can it be some toothache also? But he's also got some history of intermittent vision problem. Then you think, oh, this may be this rare entity, giant cell arthritis. So I gave you a clinical scenario, 50-year-old lady with some fever and some jaw pain. Before doing the test, what did you think was the possibility of giant cell arthritis?
Very high.
No, you can't give a number.
80%.
So before doing any test, you as a doctor look at the patient, smoker with a lung lesion. Yeah, I think there is at least 80% chance of lung cancer. It may be pneumonia, it may be TB. So that is called pre-test probability. Then we have the test. After the test, we come to a new understanding. What is a new understanding? Post-test probability. I did this a couple of weeks ago when I was teaching. We'll just do the same example. We'll do a different example. The patient walks into the OPD, a lady, fever, some query jaw pain, and you are worried about caries. What do you think now? Probability of having giant cell arthritis?
2%.
Let us say, for example, 10%. Okay. What was the sensitivity of ultrasound in your story?
50.
Against the best gold standard?
54.
54. Against the clinical, the composite gold standard?
Yes, sir.
So the sensitivity of the ultrasound was 54%. Specificity was 80% for match cycle keepers. Now this is a true story. A patient walks into your OPD with this story, and we have the ultrasound. You send them to radiology department. We do temporal artery ultrasound. Now the ultrasound came positive. You have a pre-test probability 10%. The test is positive. You know the sensitivity and specificity. Can any of you calculate and tell me, I'll give you 30 seconds, you have pen and paper on your phone. Can you tell me the post-test probability of having giant cell arthritis? So this is what you're really going to face. This is real life. This is a true patient story. You have the ultrasound. This is a study done by UK government, and it's called health technology assessment because the UK government decided to use this for the whole country based on this study. So what do you think is the post-test probability? let's do a maths. So imagine there are 100 patients like this lady who come to your OPD. Okay? And we have said there's about, he said 2%, I'm just saying 10% so the maths becomes easier. He said 10% of them may probably have giant cell, 90% may not have. So if you have 100 patients like that, 10 will have probably giant cell arthritis, and then that means 90 don't have giant cell arthritis, right? Is that correct? When you say a prevalence of 10% means 10 people will have disease, 90 won't have disease. Where did you come with this 10% number? It's just your clinical guess. You're a doctor, you have some sort of idea. Now the sensitivity, for the sake of maths, I'm going to take 50%. Because among these 10 people with giant cell arthritis, how many will the ultrasound pick up? 5. Because sensitivity is 50%. It will become 5 as being positive. That's okay? Remember, sensitivity is down, specificity is, the first row, second row is specificity. If, let me just make it easier for all of you. Sensitivity, specificity. This is false, negative, false, positive, true positive, true negative, true positive. So if the sensitivity is 50%, that is this. So of the 10 people with disease, it will pick up 50% of them. Now if the specificity is 80%, that is, this is 80%, what is false positive? If this is 80% of the total, this has to be 20%, right? Correct. So I told you specificity is 80%, because 82 or something. If specificity is 80%, false positive is 20%. Everybody understood? So among these 90 people who don't have disease, false positive rate is 20%. So how many will come positive? 20% of 90 is 18. 18 people are false positive, but they come positive. We don't know, the test has come positive. So totally the test is positive in 23 people. Correct? You do the test, it comes. Of that, how many truly have disease? 5. 18 don't have disease actually, they are falsely positive. What is 5 out of 23? Percentage wise? 5 out of 25, 1 by 5?
21%.
About 21%. So we had a pre-test probability of 10%, post-test probability of 21%. At 21%, would you tell people you have disease and start them on high-dose steroid and cyclophosphamide? You probably won't. So this is how we really use in real life this. Now, let me go back to this. Now, there's one guy, a mathematician or statistician called Fagan. He said, see, can you imagine doctors sitting in the OPD and taking pre-test probability, sensitivity, specificity, post-test probability. It's very difficult. So let me make it easy for them. You can Google this picture on your phone also. It's called Fagan's nomogram. So let us take another situation. Or let's take the same situation. What did Adarsh say was the pre-test probability? 10%. So this is the pre-test probability graph. Okay. So I don't think can I make on this?
Yes.
So there's a 10%. This is the pre-test probability 0, pre-test probability 90%. So pre-test probability 10 is here. This is 10%. Right? Now the sensitivity was 50%. Correct? Specificity was 80%. The likelihood ratio, he gave one formula, positive likelihood ratio, sensitivity divided by 1 minus specificity. So how much is that? 50. Instead of 1 you can put 100, 100 minus 80. So how much is that? So 50 by 2, 2.5. This is the positive likelihood ratio. So people wonder, why are you complicating all these sensitivity, specificity? You're making me going mad with likelihood ratio. But the middle column of Fagan's nomogram is likelihood ratio. So the test is positive, ultrasound is positive. So you can see the likelihood ratio, where is 2.5, 0, 1 is here, 2 is here, 5 is there. So 2.5 somewhere there. Correct? You all understood? Now Fagan said, just take a scale and draw the two lines together. So I'm not very good at drawing lines, but let me see if I can manage that. Okay, it's a bit bent line. So this is the post-test probability. 0, 100%, 10%, 20%, 30%. So remember we calculated from the previous example 21, it's come to about 20%. So you can have this small nomogram in your pocket. But the lab, many labs in the West will give you positive, negative, and they'll give the likelihood ratio also. So you can sit in the OPD and calculate the post-test probability of any patient having disease. Now, what is the test came negative? Then we must calculate negative likelihood ratio. Same sensitivity on top, specificity below. Just that the 1 minus goes on top. Here 1 minus is below, 1 minus goes on top. So somebody tell me that 100 minus 50 divided by 80. 50 by 80 is 5 by 8 is 0.6. So the pre-test probability remains the same. Patient doesn't have disease. I mean, whatever your clinical judgment. Now the likelihood ratio is 0.6. So this is 0.1, 0.2, 0.5. I don't know what that is. 0.6. I assume is here. Let me see if my hand is steady. So the pre-test probability is 10%. Likelihood ratio is 0.6. And the post-test probability is 0.05 or 5%. At 5%, will you confidently tell the patient most likely you don't have giant cell arthritis? Yeah, okay, you don't have to worry. I'll follow you up, but it doesn't seem. So the negative ultrasound is useful in this situation. If it's positive at 20%, will you treat the patient? No. At 20%, can you tell the patient you don't have disease, go home? No. So that's the real implication of having this thing. That a positive test leaves you in no man's land. A negative test, which is maybe what you want in OPD, yeah, at least you don't have giant cells, go home, take some antibiotic, maybe jogging, maybe you're stressed out, take some antidepressant. I'm just making fun. But a positive test doesn't help you much. The last thing I want to teach today is the impact of prevalence of disease. Now the patient is very unhappy with medicine. He goes to rheumatology, and you're sitting in rheumatology, you're the professor of rheumatology, and it's a vasculitis clinic. Only patients with suspected vasculitis came there, and they have ESR high, CRP high, and then they have some, by the time the patient has started having visual abnormality. Now what is the probability of giant cell? So let us say, for example, the pre-test probability now came to 80%. Okay, at 80% pre-test probability. What is the likelihood ratio? Same, 2.5 and 0.6. So 80% pre-test probability, you have to join this line. 80% pre-test probability. Likelihood ratio of positive test 2.5. Post-test probability only 90%. Now did the test help you much? Okay, already most likely it didn't help much. Okay, pre-test probability 80%, but ultrasound is normal. Then we must think, here is 0.6. Even though the test was negative, post-test probability is 70%. So we have to think carefully of the impact of prevalence of disease on doing the test. If the test is very high, already likelihood, then the test may not be of much benefit to you. So we should not do a test if the pre-test probability is very high. Probably you should just go ahead and treat the patient. If the pre-test probability is very low, you're not likely to be of much benefit. But if the pre-test probability is between, let us say, 20% and 80%, then it may have some use of doing a new test. Okay, I'm totally confused by all this. I can understand pre-test probability. I can't understand Fagan or his nomogram or all this maths. But I can understand some simple maths. What is the simple maths? Likelihood ratio of 1 is a useless test. The test is either making it's like tossing a coin. A positive likelihood ratio positive of 10 is very good. That means all test positive is equal to disease. So if some test is likelihood ratio of 10, a positive likelihood ratio of 10, and the test comes positive, you can tell the patient you have disease. A negative likelihood ratio of 0.1 is very good. If people have a test which is negative, with a negative likelihood ratio of 0.1, you can say you don't have disease. So that's an easy thing to remember. Oh, your test is negative. What was the likelihood ratio of the test? 0.1. You don't have disease. Go home. So anything close to 0.1 is very good. A positive test close to 10 is very good. For Adarsh's ultrasound, the positive likelihood ratio was 2.3. It is not terrific. The negative likelihood ratio was 0.6. It is not very good either. But given all this, the patient story is the same. The patient came with jaw pain and some fever, and a lady, and you're saying, I don't want biopsy. Then you have to do with whatever is best available. So you may use a negative test and tell them, okay, if it's negative, I can be pretty sure you don't have disease. But if it's positive on ultrasound, I'm not very sure to start treating you, because the treatment is not some metazine. You need to give steroids and cyclophosphamide or white. In that case, if it's positive, I may still try to reconvince you, please, you have a serious disease, probably better to have a biopsy. A little more nuanced sort of view. This is also called pre-test probability, likelihood ratio, post-test probability. This is also called what? Anybody knows? Bayes. There was a priest in 17th century called Reverend Thomas Bayes. He said, all our thinking is based on, before we have a fact, we have some idea already. Then we look at the fact. After that fact, we interpret the fact in the light of our prior knowledge. So he called this prior knowledge. This is what we got newly. From the test we got sensitivity, specific, but that's a new knowledge we acquired after getting a test. Based on these two, he put the word posterior knowledge. When prior knowledge is what you already came before the test, then you have the test knowledge, and then you have a new information using the prior knowledge and new posterior distribution. This is called Bayes theorem. So Bayes theorem is now increasingly being used in all fields of medicine. Diagnostic, RCTs, cohort studies, time series. So it's an interesting thing to read. If you're interested in this, you can read textbooks on Bayes in medicine. Increasingly, RCT evidence shows this is the NNT. But you can have already a prior idea of what you think was the value, and you can come to a newer idea. So Bayes in various fields of medicine has become quite an important field. So we just added Bayes to this thing. Any questions? None? Okay. Thanks, guys.